ways I was lucky, because for whatever reason, addiction didn't get its claws in it, with the exception of cigarettes, which is obviously a major addiction, but doesn't manifest itself in some of the same ways. But I think the part of Justin's point is really powerful, which is we live in a society where we medicate a lot of problems and we self-medicate a lot of problems. And the connection between mental health, drug abuse, is powerful. Anxiety, folks who are trying to figure out coping skills. And we have an entire industry that says we're going to help you self-medicate. And the line between alcoholism, which is legal, and folks who are taking Vicodin, and then on to harder illegal substances, isn't always that sharp, particularly among children. So one of the conclusions that we came to is that it's important for our health system to be addressing wellness in a way that prepares doctors, provides resources, insurance policies, all that can help with these issues, as opposed to if you have a broken arm, you get treatment, but if you've got significant depression, that you may be masking through alcohol or through opioids, then you're not getting treatment. And one of the things that we tried to do through the Affordable Care Act was insist on parity in insurance policies. One of the steps we're now taking in response to the opioid epidemic is to really ratchet up the guidelines that we're providing to insurers, so that if that young lady that Lena was talking about, if she has insurance, that in fact that it's treated as a disease and it's covered. And Medicaid and Medicare start really taking parity seriously, so that mental health issues and addiction issues are treated as a disease in the same way that somebody with a serious medical illness.
A little bit more detail on it. People talk about mental health parity and they say this has been around for some time, but the impact has not been felt the way that a lot of people would like to feel. What will the task force be able to do that hasn't already been done?
Well, the goal of the task force is to essentially develop a set of tools, guidelines, mechanisms, so that it's actually enforced, that the concept is not just a phrase, an empty phrase, but it's a practical matter. If you're trying to get a provider for treatment, they may or may not get reimbursed, but there's a consistency in terms of how we approach the problem. And when it comes to Medicaid and Medicare, obviously there are guidelines because that's a government program that we can provide. When it comes to how we oversee the parity provisions of the Affordable Care Act, we've got to let the insurance carriers know that we're serious about this. And this is where, though, the public education and employer education around these issues is very important as well. Because 85% of folks still get their health insurance through their job, through their employer. And for business owners, for companies to recognize that they are much better off checking and pressing their insurer to see that, in fact, mental health and substance abuse parity does, in fact, exist. They will save money, their workers will be more productive, and they'll be getting more bang for their insurance buck. That's all part of the approach that I think we can take, and we've got to carry through over the next several years.
We spoke earlier, you talked about the fact that you wanted to start the president, some of what you experienced today with the criminal justice your experiences and what that stigma really felt?
The place where I go for counseling, I talk to a lot of people that are on probation, and the probation officers don't treat them like they have a disease, and the medication is something that's treating their disease. They don't want them to be on it, and they don't understand. I don't think they have enough education. It's great to hear the president say the disease of addiction. That's wonderful. But there still is a stigma. For me, even coming here, and nobody here treated me bad or anything, but it's in the back of my mind always.
Somebody thinks we're so bad to get talk to me. U.S. Armed Forces.
But it is in the back of my mind, like, like I'm not worthy. Being really honest, so.
Criminal justice parole officers?
Yeah.
Counselors? Was this?
Some doctors even. One doctor I went to, and I talked to someone, a few people today, about the Parity Act. I don't have a problem with it now. Everything is paid for. I'm on Medicaid. But I have gone to doctors before that would only take cash. And they haven't been nice. I've had a couple really nasty incidences with things that the doctors even said about the patient and treatment, and I just want to. Yes, yeah.
What you're describing is so unfortunate, but it's so prevalent. When we talk about, for example, naloxone, the overdose medication, there are people who would question whether giving someone naloxone will make them more likely to use drugs. But we would never say that about somebody who has a peanut allergy. We wouldn't say, well, we're not going to give you an EpiPen, because it might make you eat more peanuts next time. You see that stigma in Baltimore, where I am, and we're coming up to now a year post the unrest in our city. And often it's tempting to look at what happened in our city as what's in front of us, which is angry young people committing acts of violence. But then if we look just one step deeper, we see what's resulted in deep poverty and deep disparities from our policies of mass incarceration and mass arrest. I mean, we have a city. We have 73,000 arrests made every year in a city of 620,000. And when we look at individuals who are in our jails, 4 out of 10 have a diagnosed mental illness, 8 out of 10 use illegal substances. So we are criminalizing people without giving them the re-entry resources to get their lives back in order. We're treating addiction differently from any other disease.
You provided your own name as a doctor at all the pharmacies I understand in Baltimore or certain areas, so that anybody going in could get their Narcan or naloxone if they want. Is that right?
That's right. So we issued a standing order in the city, which we strongly believe that everyone should save a life. That it's not just first responders, which is very important. We actually started training our police as well, and within 6 months, our police officers have saved the lives of 21 citizens. So that's very important. But we also believe that if it's true that addiction does not discriminate, and it does
syringe service programs, are they more likely to enable or cause continued usage of these drugs? Did these discussions come up as part of trying to pass some of these recommendations?
These discussions come up. The good news, I think, is that we base our guidance and our policy on science. And when you look at the science, there's no evidence that because of a syringe exchange program or naloxone, that is thereby an incentive for people to get addicted to drugs. That's not the dynamic that's taking place. This is a straightforward proposition. How do you save lives? Once people are addicted, so that they have a chance to recover. It doesn't do us much good to talk about recovery after folks are dead. And if we can save a life when they are in a medical crisis, then we can now make sure that they can also recover, so long as the treatment programs are available. I think what Lena said with respect to our populations in prison and the lack of systematic programming for them and support when they get out is a critical because if somebody has gone to jail for a nonviolent drug offense and they are not getting treated and provided with some baseline skills and some hand-holding when they are released, they are going to get back into trouble. That's just human nature. And if we're being smart on crime, not just thinking in terms of sound bites, and this is going to be an area where we provide more resources, and the Department of Justice is working very closely with our Office of Drug Policy to find ways that we can improve at the federal level reentry programs, drug treatment, and so forth. Now, keep in mind that the vast majority of the criminal justice system is a state-based justice system. The federal government is not responsible for the majority of drug laws, the majority of incarcerations, or how the reentry process works upon release. What we are hoping was we model best practices based on evidence that more and more states will adopt it, and there's an incentive for states to start doing so, and that is cost. If you can reduce the amount of recidivism, and you are saving money. If an individual like the young man I met in Camden who was in prison for drug offense, that kid comes out, gets treatment, gets support, and gets training, and is now an EMT for the state of New Jersey. That's and now is paying taxes and supporting himself, potentially supporting a family. That's good for everybody. But that requires a certain amount of foresight in terms of how we're approaching this problem generally. And the same is true, by the way, for preventing people from getting addicted in the first place. I don't want to... Probably talking about recovery, because we've heard powerful stories from Crystal and Justin, and they're inspirations for people who are watching. I could not be prouder of them sharing their stories. What we also want to make sure of is that a third grader has support who doesn't make him feel the need to engage in this kind of more destructive behavior. It's something that we got two doctors on this panel, so maybe they can address it. But as a layperson who's studied this, we have a healthcare system that too often is really a disease care system. We wait until people get sick. Thinking about how do we keep people well and healthy and balanced and centered in the first place. And that would, I think, a reimagining of how our health specifically when it comes to opioids, the training of doctors for pain and pain relief and how they help their patients manage pain. This is an area where I was shocked to learn how little time residents in medical schools were spending time just trying to figure this stuff out. It is not emphasized, it's not considered prestigious or trendy to think about how are you managing pain with your patients. And the good news is, part of this initiative that we've got moving, we've got 60 medical schools who signed up, who are announcing today that they are going to make pain relief a major part of their curriculums, a major part of
It's really stunning, man, because I tell you, it seems like for a period of time, Dr. Leonard, you can share your experiences that pain relief was talked about a lot, but only in the context of getting out drugs. The literature would all suggest, if you look back at those small reports, that there was no concern for addiction. And every single time someone came in from emergency, even for a non-pain related thing, they would be asked about it. Perhaps given 80% of the world's pain pills are consumed in the United States. We are 5% of the world's population. We take 80% of the world's pain pills. We don't have 80% of the world's pain, my guess. What do you think, Doctor? How did that happen?
Two things happened. One is that drug companies very aggressively and I don't know if it's knowingly or not, but they misled and marketed pain pills to physicians and patients. And we then developed this culture also of a pill for every pain. If I fall down and bruise my knee, I may not need opioids. I'm sure I do not need opioids. But somehow we have said that our goal is to make people pain-free. And so, I've worked with many great doctors. I trained with many fantastic people, including Dr. Murphy, our Surgeon General. And I know that doctors are trying to do the right thing. We're not trying to get our patients addicted to medications. We're not trying to get them to switch to heroin later. We need the resources to help us to then support us, whether they are the guidelines issued by the CDC, or whether they are other efforts by our medical societies to assist us to make better decisions for our patients. But we also need our patients, and we need society to change too. Because if I talk to one of our students in Baltimore City and I ask them, is heroin good or bad? They're going to say heroin is bad. But if they see that every time that they're acting out in class, that they get diagnosed with attention deficit disorder and they get a pill. Or they see that their parents are in pain for maybe they sprain their back and they see their parents getting a whole month's supply of Oxycontin. I mean, this is the culture of excess that has to change.
That's what I think about us reimagining how we think about health and wellness. There's a good analogy to this, and that is in the whole field of antibiotics, where one of the things that we're spending a lot of time with my team and NIH and CDC and FDA, we have to worry about is the fact that antibiotics, which are one of the great breakthroughs of mankind that saves billions of lives because of their existence, are becoming less effective. Because every time somebody's got a cold, and I've been guilty about this as a parent, I don't like seeing later such as sick. And so I go to the doctor and I say, well, can't we do something for it? And sometimes it's just a cold, and an antibiotic's not going to work, but the over-prescription antibiotics has led to increased resistance among the bacteria that need to be treated. And so the doctor's right. We have to change the medical profession and the drug companies. We have to hold them more accountable. We as consumers and as parents have to be more accountable as well in terms of how we approach keeping our families well in order for us to be able to prevent this massive gateway into addiction that can cause real problems.
And as back, because you mentioned that, Dr. Freeman's here